Okay, so we're going to talk about hemodynamics and PA catheter insertion, removal, and mixed venous sampling, and how to do the cardiac output and hook it up to the monitor and that kind of thing. Okay, so just a definition: anything that defines anything that defines the physical factors in governing blood flow throughout the body would be basically what we're looking at. So we're going to be focusing on PA catheters. Sometimes they're called Swan-Ganz catheters. These are kind of some of the indications: septic shock, cardiogenic shock, heart failure, or fluid volume status issues. So, like I was saying, we're going to talk about PA catheter bedside placement and getting your cardiac output numbers and obtaining a wedge. Look at a couple different waveforms, mixed venous sampling as well. So when we're talking about PA catheter placement, sometimes it's hard to visualize where the PA catheter is. It's always good to have a good anatomy baseline as far as remembering where it goes. It's going to loop when it's coming down. It's going to loop into the atrium, and then it's going to go up and into. Most of the time, it's going to go towards the midline of the body. Main reason for that is that that's the predominant blood flow for most people. You have 3 lobes over here. Predominant blood flow is going to carry that balloon into that space. In the book setting, it actually just looks better because it goes that way. It doesn't cross over itself. But actually, most of the time, we're looking for it to cross over the midline. So, okay, so let's say you're going to put in a PA catheter at the bedside. What are some of the things you're going to need? Critical care box should have the PA catheter in it. If you're in ICU, sometimes we'll actually get the PA insertion box, which you can get from SPD. The basic supplies you're going to need your trifurcated system for pressure system, 500 cc bag of fluid. Also, you're going to need the introducer kit as well. And this is your cordless introducer. There's a couple things in here we tend to forget that actually are in this kit besides the introducer. The actual sleeve that covers, the plastic sleeve that covers the PA catheter, sometimes that gets kind of lost in the shuffle if you're putting it in a hurry, but it actually is in that box as well. Okay, so make sure you remember to remind whoever's putting it in if they happen to not see it. Also, we do use the obturator cap, or the little blue cap that covers the tip if we're not actually going to put a device in the introducer, or if we take it out and we want to maintain sterility of the tip so we could reinsert a catheter into it. If you happen to not keep the one from the package, we actually do have a stash of those in Running Green in our equipment room. So, all right. So, what are some of the things you could do as far as setting up your lines beforehand? It's always a good idea to prime your setup. Don't throw trash on the floor, but since I don't have a trash can, that's what I'm going to do. When you take this out of the box, this is the trifurcated set. When you take this out of the box, it has that nice little paper banding that everybody loves. That actually, there's a reason for that. It's to keep it off the floor. So just if you remember that and you don't break them initially, it actually will make it easier for you to keep up with your lines if you're priming them ahead of time. That way they don't just arbitrarily just fall off and hit the floor. Now I brought this up so that you can kind of see. You're also going to need the pressure bag system, or pressure bag as well. So there's a couple different ways you can get the air out of this 500 cc bag. Some people prefer the well, I'm supposed to have a cap on this. The needle aspiration through this port right here. That's fine as long as whatever you're doing is maintaining sterility in your process so that you don't introduce anything into this closed system. Okay. Some people find that it's really easy just to kind of pierce the insertion port right there just a little bit, and then just kind of squeeze. If I can do it without making a mess, you just squeeze the bag, and then you can get a majority of your air out that way. So that's just another way of doing it. And you can also purge whatever's left in this chamber through the system whenever you go through here. Now you're going to be priming it with a gravity prime. Also, if you remember, when you take these out of the package, a lot of times these connections are loose. So just go through and do a real quick little check on your connections and make sure that they're not really loose. Tighten them up. It also is set up for what you might call a progressive prime. Okay, progressive priming, these are vented caps, and they're vented so that they can be primed and then left on to keep the cap sterile until you're done with the zeroing portion when you insert it, and then you can take them off and replace them with the yellow caps, which are the closed caps. So the progressive prime, what I mean by that is that the stopcocks are turned off to the distal end. So as you go through and you're priming this system, you can see that, I'm making a mess on the floor, but you can see that once you get all of your air out of the line there, you just turn the stopcock, and then it's going to continue on to the next step. And it's kind of a good thing to remember if you just go systematically through here, because there's a couple things. One, with the arterial line, making sure that you do pull this back a little bit, so you've got a little bit of a dome to the safe set. And the reason for that is the air trapping that can happen in there. That's actually a manufacturer recommendation. So keeping it pointed up, and I guess I'm starting to get close to being a problem here there. So anyway, you're going to prime your system. Sometimes you do have to give it a little bit of a squeeze. You mind doing that for me? See, that's the advantage of you sitting on the front row. All right, so basically, there we go. And I say we're doing it under a gravity system, but sometimes you do need just a little bit of pressure to move it forward, and that's okay. The purpose and the reason behind not doing it with a pressurized system is because you don't want to trap any air in there, because 3 cc's of air in a syringe with no pressure on it looks like 3 cc's of air, but you can press it down and you can almost make that syringe completely depressed, so that it looks like there's no air in it at all. But actually, it would go into the arterial bed. So I'm going to take this off, clip these in real quick, and the order of this. Some of these cards are already set up. The most important thing about it is that you're connecting the correct cabling to the monitor and to the patient, and it's consistent all the way through. If you want to switch around which one to wear, most of the time just keep the labels consistent. It's usually arterial, CVP, and PA, depending on what your preference is. Okay, so with this being primed, if we had an arterial line, of course, that's going to be available for that. And we'll progressively prime this. And if you don't press all of the air out of this chamber, you can see the movement of the flush, which is kind of a nice thing if you're concerned as to whether it's actually flushing or not. So, good thing it's carpet in here. Okay, so then you've got your system set up and you're ready to go. Now, as far as connecting it to the monitor, you can go ahead and do that if you want to. Sometimes that just makes the alarms go off. If you happen to not remember which one switched, let's say you haven't hooked up a PA cath line in a long time, you don't really know exactly which one plugs in where, you have your little piano bar right there in the bottom of the screen, and it brings up the legend that tells you which one switched. And of course, it's arterial, PA, and CVP. And then the other part, which is going to be your cardiac output. Okay, a lot of times you may not be able to access the functions of the cardiac output if you don't plug the cardiac output cable into the monitor. So that way you can put in your numbers, your height and weight, and those kind of things. So we can follow that legend. Remember, I was saying consistency from one end to the other, making sure that you have this connected to the correct one. So snap those in. See, there I go, doing it the wrong way. All right, so your PA, which is going to be this one. See, it can be confusing, so make sure you're following it all the way back, and you've got it connected correctly. All right, so once we have those up and we're ready to set up our system for whenever they are ready for us to connect it to the PA catheter. So other than that, full drape is recommended, of course. This is a central line insertion, so full drape of the patient would be ideal. Whenever they open this up, the main parts we're going to be using, this is what's going to be inserted in the patient. Okay, I'm going to pass this around so you can kind of see how that can get kinked. making sure that that's sticking straight up is kind of important. This comes in a little plastic package. I've lost that on this one, but this is the obturator cap I was talking about, little blue cap. Okay. So once you have the introducer secured, this part is the part that if you haven't done this in a while, as far as assisting with an insertion, sometimes it can be a little bit, people get a little bit uncomfortable with it. But it's just, mainly it's just sterile process is all it is. Making sure that you do this, hand this off to the practitioner, and let them open the inner package. Okay, that's kind of the other part that's easy to kind of get mixed up about. Because if you forget that, then you have to open this up and let them take it out of the package. And that's kind of a pain, to be honest with you. So I'll show you what the practitioner is going to do is open this up, and you can kind of see how this kind of comes in the tray. The reason why this is in a little preformed curve here is so that when the practitioner is putting it in, that it has that natural curve, so it'll hook into the atrium, whether you're coming from femoral approach or from IJ or subclavian. Okay, so what they're going to do is, and since you're sitting here, I'm going to get you to help me. You're like, man, I shouldn't have sat on the front row. All right, so they're going to hand you the syringe, which is a 3 cc syringe set with a barb on it for 1.5 mLs. And that's, you can't use any other type of syringe on there because you could overfill the balloon and you can rupture the balloon. So they're actually going to either put the syringe on or hand the syringe to you, and then they're going to sterilely hold on to this, and they're going to hand this off to you. Okay? So now they have this end, and now they're going to ask you to do a couple things. They're going to ask you to check your balloon, make sure that it's going to work, and it does. And you notice whenever, if you didn't see it right there, but whenever she got done, she didn't pull it back on the syringe, passively let it deflate. The balloon naturally will push the air back out. And if you pull on it, it actually can weaken the balloon and cause it to rupture. Okay? So a couple of the other things they're going to ask you to do is once you hook it up to here, they're going to ask you to flush through each one of the ports. Okay? Thank you very much. And when you're looking at these right here, you know, if you haven't done one of these in a while, you're not really sure which one's which. There is a little bit of a reminder on here. It does say proximal, distal, and your medial or your RV port. This particular swan is an RV swan or a pace port swan, which will accept Chandler wire, which we talked about in pacing earlier. So the only other piece to that you need to remember you need to have with you, and this is why it's good to kind of have a punch list in your mind as far as what you need, and the critical care box has all this stuff in it, with the exception of the flushes. They usually have those in the room. Is you need some kind of a simple clave, and the simple clave is for the RV port. And whenever you're going through and connecting these lines, say we're going to connect the PA line. And just to show you an example here, I'm going to connect the PA line. Now, it would be, if you're not getting any flow through this, it would be okay to go ahead and pump up your bag a little bit and kind of force the rest of that through if that's, but you can see that coming out the distal tip now. You can see the water dripping out the tip. And so your system's primed. Now, when you're going through and priming the RV port, it's just as simple. You're going to take your clave out of the package, make sure you get all your air out, put that on your RV port, and same thing. And there you go. So, and same thing with your CVP line as well. And as for demonstration, I'm going to connect it actually to this swan right here. Everybody still see? So this is my PA that I had connected. And get this connected all the way here. It can be a little tedious. There's a lot of different lines. Like I say, if you forget which one's which, it's got the little reminder on the tip. You see, it was nice to have that paper already on there because otherwise it would have hit the floor already. And guess what? That means you get to prime a new system. So once you have this connected onto your swan, they're going to start floating this catheter in. So what's the first waveform we're going to see? First waveform that we expect to see on the monitor is going to be your PA, okay? As they're floating this in, and we're going to see that in the, on the PA line is what I meant to say. We're going to see on the PA line, I didn't say it right. I'm looking at the PA line. You're going to look at the PA line and you're going to actually look for the CVP tracing on the PA line. So when you're looking at your waveforms, you're watching, what I meant to say was you're watching the PA line, if I say it right. But you're looking for a CVP tracing, which is going to tell you that you're in the right atrium. Once you know that you're in the right atrium, they're probably going to ask you to inflate the balloon. Now, communication, just clear communication is really important whenever you're doing something like that, because, you know, let's say they say, you know, they're in the right atrium, balloon up, you put the balloon up, and you're standing here holding it. That's great, okay? What happens if you let go? Balloon goes down. Then they're driving a harpoon through the heart instead of a nice little bubble tip catheter. So I tend to want to make sure that we communicate to the practitioner, say balloon up and locked, okay? When you say locked, there's a little lock device on here, and whenever the little red lines are not in line, that means it's locked. When they're in line, that means it's open. So it's kind of like, you know, a track. It won't flow through the track if it's offset like this, okay? That's about the only time you really use the locking device on here, because whenever we put this in the position where we would leave it once the wedge balloon is down, we want to make sure that there's no air in here and that it's open, because from all the way to the back of the room, you could tell me that there's no air in that balloon because you know that it has somewhere to go and the gate's open. So that's kind of a way of ensuring that you don't accidentally have your catheter left in wedge. So once the balloon's up, they're going to ask you to, and you communicated that to the practitioner, they're going to ask you to make sure that they're going to be able to see the monitor. They're going to be watching that PA tracing, and you can see this is an example. This is really a really condensed sample, okay? So you can see your CVP on your PA line, CVP tracing, which is in your right atrium, shows the placement there. And once you drop through the valve, you go into the right ventricle, and it's going to change dramatically. You're going to see that big RV waveform, which is much more dramatic. You got to think how much movement's actually happening in the ventricle. That's why you're seeing a lot larger pressure tracing. And then once you get looped up through the valve there into the PA, you're going to see the waveform change again. Okay, and that's the ideal waveform that we want it to stay in. Kind of at all times when we have the catheter in, when we're talking about the PA distal port. The next tracing is to make sure that it's in correct position, which would be the wedge tracing. And now, when you think about the pulmonary arteries, they're progressively tapered. We're going to watch that balloon kind of wedge into that pulmonary artery. So, you know, as it's progressively going through, you're going to wait for it to wedge and get wedged in that position. Now, once you get into the wedge position, you're going to see your wedge waveform, which is more kind of resembling a CVP tracing, really. Okay? They're going to ask you to deflate the balloon, and you would hope for it to go back to PA. Okay? That would be ideal. Now, it's always a good idea to go ahead and check it again, just to be sure that you're going to be able to get it to wedge again. So just let them know what you're doing, communicate to the practitioner so they're not going to be repositioning the line. Try to wedge it again. Hopefully your wedge waveform comes right back up, and you're going to be able to see that on your PA tracing. So that tells you you're in good placement. Okay? Anytime you place a line like that, whether it be like any kind of a central line, of course, we always get a post X-ray. Okay? So that's important too, and I'll show you an example of that a little bit later for placement. So once you've gone through and you've got it in correct placement, oh, actually, it's the next slide. So we'll talk about that. This is actually a subclavian line. So you can see it's coming in right off the right side of the chest there and then dropping down into the central. And then as you can, I don't know if I have my pointer here somewhere. Here we go. What's that? If I use the mouse? Okay. All right. Here we go. Okay. So subclavian is coming in here. Now, if this was coming from the IJ, we would expect it to be coming down more in this line. but it's going to drop into the central, and then it's going to go into, now it kind of drops off the bottom of the screen here, but that's the loop that goes into the right ventricle. And what you're looking for is the tip of the catheter right here to be at or a little bit across midline whenever we're talking about where the catheter is. One of the concerns about it being in too far would be that it would spontaneously wedge without, any prompting. It would just get tight in that vessel. Or if it's too far back, that it would fall out into the ventricle and would cause ectopy and cause arrhythmias and whatnot. Okay? So making sure that you're looking at your x-ray, compare it to yesterday's so we can kind of have a baseline and know if you have that available. You can see, hey, we had the CHF patient who came in and was on BiPAP and has been diuresed like 6 liters in the last 2 days. Okay, and now our PA catheter is so far in, it's about ready to wedge on its own. It's because when you're thinking about volume, think about the ventricles and the amount of space that you have. So if that volume space is big initially, you're going to have more area. So then as you've diuresed your patient, now the ventricle gets smaller, it's going to be farther in. Okay, and you can pull the catheter back. 3 centimeters is 3 to 4 centimeters is usually about the most you'd want to move it. Okay, without any kind of a physician intervention otherwise. If you move the catheter at any point more than 5 centimeters, whether it be physician or practitioner advances it, because we can't do that, or if we pull it back more than 5 in any instance, you'd want to, or if you had to refloat it, you had to pull it back to a CVP position, which that would be that you had to pull the catheter all the way out to where you see that CVP initial tracing like you did when we were putting it in. That would be another indication if you had to replace it to get another chest x-ray, is my point. Anytime you move the catheter 5 centimeters or more, you really need to get another chest x-ray. So, all right, so let's go on to the next one. All right, so this is just a correlation example of arterial PA and your basic EKG rhythm. So just to give you an example as to where that phase is, your diachronotic notch and how that falls on the PA waveform. Now, this is a reference scale for normal values, and we'll do some numbers here in just a second. I actually have some reference cards made up, which I'll hand out in just a little bit, that have this on one side, and it actually has a decision tree as to why is your cardiac output down, why is your cardiac output up, different little reference things that it's in here as well. So let's talk about cardiac output and cardiac index. One of the first things they're going to want you to do once you've confirmed your position for your PA catheter on insertion is to get a first set of numbers. They're like waiting. What's my first set of numbers? That's what they want to know. Okay, because they want to see what they really have that they're working with. So, stroke volume times heart rate, simple. That's your cardiac output, right? Cardiac index is consideration of your BSA. Okay, so it's cardiac output with your BSA. So it's basically cardiac output specific for you. Okay, considering your patient. So if we have that patient that's, 300 kilos, you're going to have a lot more to perfuse, so you're going to need a whole lot better cardiac output. And, somebody who's 4'11" and barely 100 pounds is going to be a whole lot different situation. So that's why there's that correction factor, okay? And there's a lot of different factors that can affect these. This is that flow chart I was talking about. And I'll kind of leave that up so you can kind of go back to it. But this kind of gives you some examples. Your heart rate, stroke volume, kind of breaks it down to the very basics. And then what is affected in its situation, preload, afterload, contractility. That's really the trifecta of what matters when it comes to hemodynamics. And then kind of carry down from there. So to satisfy your physician for their first set of numbers, and anytime you're shooting numbers, which, by the way, are standards of practice with a PA catheter in the critical care setting is to do cardiac outputs with these every 4 hours. So making sure that we're kind of keeping up with that. This is the cardiac output set. Okay, it doesn't come with a bag on it already. I already had this bag, but it would leak everywhere, so I didn't pull it out. But again, with the same concept of trying to get the air out of the bag, want to make sure that you don't trap any air in here. You can see I've got a little bit trapped in here, so we'll let that out. But the one thing I wanted to show you was that this comes in pieces. So it could be a little bit confusing when you take these out and it's wound up in the package. You just have to untwine that. And if you look at this, there's the valve right there. And this connects to your patient side. The side that has the TENG connector side for the cardiac output, that's the one that goes over here. Syringe goes on the other side of that, okay? So you're going to thread that on. Let the rest of the air out of this bag. And then you're going to, if the clamp happens to be clamped, it doesn't come that way, but that's another thing. If you can't figure out why your system's not pulling back, it's probably clamped, okay? So you're going to pull back, and you can see your syringe works just like a regular syringe. You can see you've got air trapped in there, and there you go, okay? So you've got all the air out of the system, okay? So this does not have to be on a pressure bag, by the way. The other component to this that you have to have is your cardiac output cable. Now, there's a piece that could be missing here. So if you see a cardiac output cable that looks like this, you're missing the important part of the TENG right here. So hopefully those are staying with this, but if it happens that you end up with one, if you don't have that, you can't functionally do a cardiac output. And the reason for that is this, again, like I was saying, connects to the side here to give you the atmospheric temperature, okay? This is going to connect to the temperature port on your PA catheter. So we've used just about all the ports so far. We've got our clave on our RV port. We have our CVP, which is your PA, and your PA port as well connected, and then your temp port's the only thing left. Okay. So just a little bit of a note. There's little bitty wires inside this, so don't rotate it when you plug it in, because if you break one off, then you're not going to be able to do thermodilution cardiac outputs unless you replace the catheter. That means the physician has to reflow a catheter. So try not to break those off. It doesn't happen very often, but if it does, you're pretty much out of luck when it comes to doing outputs until you change that out. One of the things we tend to forget, and I don't have a label with me, but making sure that we put a label on here, okay? Now, we also have a trifurcated set. So just rapid math here. We've got these that run at 3 cc's an hour, right? We've got 3 lines, and most likely you're going to run pretty close to being over half of your bag before a 24-hour time period's up. So it's not a bad practice when you come in, part of your assessment of your patient and your equipment, to make sure that you either it's been replaced in the last couple hours or that you just probably go ahead and replace it. Because like we were saying before, when your bag volume drops to 200 in that range, 250 or less, you start to get inaccuracy, and it doesn't maintain good pressure, and you don't get that full effect of the 3 cc's like it's supposed to be to keep your line patent. Okay, so label your bag and put it in your pressure bag. And this will go up to the little green zone on here, and that's about 300. So now your cardiac output bag does not need a pressure bag, and actually saw one like that set up that one time. I guess it didn't hurt anything per se, but it really, I don't know the purpose behind it. So anyway, so make sure you've got this set up and it's on your 300 and you got your pressure ready, all part of your initial setup. You've got your cardiac output syringe ready. We're going to connect that up. Now, there's not any discernible research that says that this has to be hooked up directly in line with this. Now, physics might be easier to do. I don't know. I really can't find any difference. So connecting it to the side of this port is acceptable. It's a matter of however you want to do it. Doesn't matter. Okay? And making sure that we have all the caps that we're not using. We'll use these blunt caps. Of course, change them out on our system as well. I'm not going to do that right now, but that would be, you replace the vented caps for that. And I'm going to put one on here. Okay? So for your cardiac output, we've got your TENG connector connected. We've got your cardiac output for your T blood temperature, for core temperature. And the theory behind this, of course, is thermodilution. So you're going to sense the patient's core blood temperature. You're going to give a bolus of 10 cc's of fluid. There has to be at least 11 degrees Celsius, I believe, difference between the atmospheric fluid that you're giving and the patient's actual temperature. So if you have a really hypothermic patient and your room is, really cold, and you might actually get close, maybe too close, if you're really in that hypothermic phase, it doesn't happen very often, but if you start getting an error and it tells you on the monitor that you're not within range, then you know that that's probably what it is. Okay, so we get ready to do our output. We're going to turn the gauge, or excuse me, turn the stopcock valve off to the pressure line right here and open to the patient. So think about a track and how that fluid is going to travel. Now on the monitor system, this is in demo mode, which exists in demo land, which is not real, by the way. But you can see all these wonderful, nice, pretty tracings, okay, which is great. And we hope that's how our monitor would look. But if their patients look like this, they really shouldn't be with us, probably. So what you're going to look for is on the bottom line of the screen here, we're going to find our cardiac output, which is listed there. There's a couple things you want to note here, okay? When you're putting a new line in, if you're the first one who's doing this output, and actually when you do each one of your outputs, you really should confirm this, but especially at the very first one. Confirm your compu constant, and what that means is that we're all talking the same language, basically. The compu constant for the PA Paceport Swan, 0.59 or 0.592, if I can say it right. And where would we find that constant? It's actually in the package insert, and it'll tell you which one you're looking for. And if you happen to not, you lost that, now what do? These are Edwards products, and on their website they actually have that conversion scale right there, and you can match the model number on here directly to that chart, and it will tell you which compu constant you should be using. Okay? Not that we really use a whole lot of different swans, except for this one, or without an RV port, sometimes from Cath Lab. So anyway, you're going to confirm that. And the other thing is, of course, is your BSA. Now this one is in inches, so ours is in inches as well, but also your weight, your height and weight. Your weight in this one is actually in pounds. In our monitors, it's in kilos. So please don't get confused, but when you go to put it in, make sure you're using the correct units based on what's in the monitor. So, okay? And so what's a perfect ideal patient weight? 150 kilos? 150 kilos. Pounds, okay, yeah. That'd be great. So we're 72 inches tall, so we're nice and tall, and we're 150 pounds, right? So anyway, that gives you your BSA. It automatically does that and calculates it for you. And if you all noticed that whenever I went to change that, I just tapped on the screen right where it says BSA, comes up over here, and then we can put those numbers in. Same thing with a compu constant, okay? So it's easy to access. All right, so now we're ready to do our first set of numbers. We have all the components here to do that. We have our line set up. We've got our cardiac output syringe connected, our tinge connector, temp, compu constant, BSA, all that lovely stuff that's confusing, right? Then we're going to do our first set of numbers. So start CO. Now this is where your time frame starts for your injection. You have, I think it's 15 seconds or 20-second time frame, if I'm not mistaken. Basically, it needs to be done very rapidly after you start. You don't want to prolong that because it's sensing for that steady state temperature in the patient's body, and then the bolus of fluid coming through, it's going to sense that temperature change. And if I wait too long, it'll say too long, basically. It'll tell me I was waiting too long. So I'm going to go ahead and stop that one. Let's go back out and go back in. And our numbers are in there. Well, okay, now it's going to let me go start CO. Okay, so we're going to start CO. We have our fluid ready. There's a reason this has a double pistol grip. I'm going to give the demo inject on here, but there's a reason there's a double pistol grip, is you're going to push that in very quickly. Okay, is it 4 seconds? It's a very quick time frame. I know it's right there very quickly in the very beginning. So whenever you do your cardiac output, hopefully you're going to get a nice bell curve here. The bell curve is going to give you, going to tell you basically that your fluid traveled into the right space, going to get back across, and your temperature went back to baseline. You're looking for a very quick up curve. That means that you injected it quick enough. Okay. If you kind of prolong the injection and you're just kind of going like this, you're not going to get a good example. Yeah, I've got a leaky right ventricle. Yeah, beware of the leaky right ventricle. So, but anyway, you're not going to get very accurate numbers, and so let's do another example. This has several demo injects in it. Like I say, it's in demo land, so this one's maybe not as pretty a waveform. It wasn't quite as quick up curve. And the down curve, when it comes back down and it's coming back down very quickly, that means that you've got good cardiac output and that it's clearing it out, and you've got a great heart. So if it's going really slow, then you're not really dealing with a good situation, most likely. Which our cardiac index on that, by the way, is 1.8. So it's pretty representative of what it looks like. So there's several different examples in here. So usually you're going to do about 3 of these, okay? 3 injections at least, and then you're going to take an average out of that and get rid of 1, most likely, okay? So this gives you an opportunity for error. So, all right, so once this one's calculated in, how do we get rid of the one we don't want? You just tap on it, right? And you'll see that it grades out on the monitor here. And when it's grayed out, that means it's not included in the average, okay? So once you've done that, now the way that you get this to where you can actually get it through DAS system is you have to save your CO. Save CO, now it should be available in the DAS system. If not, you have to go back in here and look at it, but it is saved in the monitor at that point. All right, so then you're going to go to the next step, which is not usually on the second screen, but there it is. So hemocalculation or hemodynamic calculation. Let's say, see, I forgot to turn my CVP. So my CVP on here, say it's 300. So all I have to do is just go over here and turn this, wait a few seconds, let it correct itself, and then I'm going to say resample vitals, which is right there, and it'll pull in the correct number, and it'll give it a chance to correct itself, and then pull in the correct number, okay? So the only thing that we don't have listed in here is your wedge pressure. Sometimes you can do that first and go ahead and plug that number in. The only thing that's really going to give you differently is your PVR is not going to be calculated if you don't put a wedge pressure in. Not a lot of physicians use that as a number that they base a lot of changes on. Some do. So if you need one, that's how you would get it. You put your wedge in there and do your hemocalculation. So now that all that's in there, we're going to perform calculation. And that's going to give us our numbers with the cardiac output and index. Okay? All right, so any questions about cardiac output? That would be where we're next. We're going to go to obtaining a wedge. We already kind of saw the examples of wedge whenever we were inserting the catheter, when we saw the catheter being placed. The wedge function on here, if you just tap on that, it's right on this one, it's right beside the cardiac output. So when you're injecting the air in this, you're going to do a nice steady, slow, steady injection, and you're going to wait for it to change from that PA waveform to a nice wedged waveform, okay? And it's going to capture that waveform. And again, passive deflation. Now this one's not going to do it because my balloon's ruptured. But on a regular patient, this is going to passively deflate and is going to push back, okay? Now, we would want to see this go back to a PA tracing in this demo mode. It's not going to do that, but we'll go ahead and edit this wedge as well, okay? So there's a couple different things when you're talking about wedge. And effects of respiration with waveforms. Okay, so where do we measure the inspiration or expiration? There's a really easy way to remember this. Okay, if your patient's ventilated, it's in the valleys. So whenever you're looking at your waveform here, if you have your respiratory deflect from respirations regarding your ventilator, it's going to be ventilators are in the valley. So you're looking to that first initial change, not the very bottom, but the first initial change right there. So this one, you can move your reference line up or down. This one, I'm going to move it down a little bit. So that gives you your correlation. That's your cursor and tells you that's what your wedge pressure is. Now again, just like with your cardiac output, you have to confirm this or you have to save it. This one actually is store wedge. So you have to hit store wedge. Otherwise, that does not go into the DAS system. Okay? So, and it doesn't pull it into the monitor. So once you've done that, hopefully it would have already gone back to a PA waveform. The demo doesn't show that. But you always want to confirm that once you've done your wedge that it's gone back to the PA waveform. Okay? And again, I'm leaving this connected with the gate open and the syringe depressed. So that way if there was air trapped in there, it would go through. Okay? There's also another example here. talks about your respiratory effects at your end expiration. That's the other thing that's important when you're doing your injection for your cardiac output, is to make sure that the time frame is when you're injecting it is at an end expiration, so that the most neutral time frame for the thoracic cavity is what you're looking for. Okay? All right. So here's a couple other examples, waveforms related to, these are actual ones, you know, instead of the demo world. Thought we might give some more real-time examples here, but you can see there's some respiratory movement in there. So if this patient was ventilated, you would expect that your reference line probably, if this were a wedge, I'm just saying, if this were a wedge, it would be more towards the valleys if it was ventilated, in other words, okay? This is a representation of a PA, though, okay? You can see the PA waveform there. Now this one actually is this is a better one for that. And it shows you, this goes from PA and into your wedge waveform, okay? There's not a whole lot of respiratory deflect in this one or movement, but nonetheless, okay? And again, like we were talking about with the cardiac output, making sure that you have that quick, steady upstroke, and you're looking for a smooth decline, hopefully not too far out before it returns to baseline. That's an example of how well your heart's pumping. All right, so let's talk about mixed venous sampling, okay? Mixed venous sampling, how do we confirm, because, you know, we may get cardiac output and index that looks okay, or, you know, maybe doesn't look like our patient looks. So we get a cardiac index that says that our index is 2.5, and we look at the patient and they haven't made urine and they look kind of blue and they're cold, and we think that can't be right. So how do we confirm that? This is one way you could confirm it, okay? You can do a mixed venous sample. Now where will we draw that mixed venous sample? We're going to pull it out of the PA line. Now this is the only time you're going to be accessing this. Of course, you know, whenever you're talking about kind of the basics and parameters about PA lines, you never, ever, 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 ever infuse through the PA line, right? This is a big no-no, infusion. Don't do that. Okay, so what we're going to do with this one is the only thing you really do with the PA line, besides monitoring it on the waveform, is to draw your mixed venous sampling. Why do we draw it there? Because that's the most distal place. That's the last place we can access the blood before it's reoxygenated, essentially, okay? So to access this, we're going to draw this. We're going to just use just a simple 12 cc syringe is fine. And you'll pull out your waste off to the pressure line. And we're going to pull out you don't want to draw too hard on it, but you can pull back steadily. And hopefully you'll get a good, nice return sample, and about 5 to 6 mLs would be very adequate for making sure that you've pulled enough out. Now this is a heparinized syringe. We have a couple different ones, but this is just an example of one. The heparinized syringe, the reason you're using this one is because you don't want it to start clotting, of course, whenever they go to run it as a mixed venous. A couple things on that syringe, whichever one it is that you use, usually they come with the same basic principles. There's this little cap. When you say, why do you have that? The importance of this is once you're done with the sample, you need to put this on and to put blood up into the cap. That makes sure you don't get air trapped in your sample and can cause skewed numbers, okay? So we'll put the air out of this heparinized syringe. We've already drawn our waste. And when you're talking about technique and the way that you go about drawing this, when you go to connect this, it just slides in there. And if you happen to, when you're drawing this, if you could just point the tip up, you don't get air trapped behind the sample, okay? That kind of makes sense. Whenever you go to pull this back, the blood accumulates in the base of it so that it doesn't get this air trap behind it. So if you pull up like this, sometimes you'll get this air bubble that gets behind it, and it can skew your numbers theoretically. So if you pull down to get your PA sample, and you usually only need about a cc, okay? So we're going to turn this off. Now here's where the cap comes in. Part of the cap is it's a vented cap right up until the blood hits it, and then it becomes a blunt cap because it's got a paper filter on here, and when the paper filter gets wet, then it stops allowing air to pass through or anything. So you would just push the blood up with that last little bit of air that was in there and get blood all the way up into the tip and up into this little tip cap right here, okay? Make sure you've got a real sealed, good sample. Give this to your respiratory therapist. You're going to run that, you get your mixed venous back. Okay? What's the normal range for mixed venous? So we're looking for, now this isn't an ideal world, right? Okay? So if any of our patients look like that, they shouldn't be probably in our unit. So, but we can say that you can basically function with it when you're right at a 60, 65. Okay, that's going to equal out to a cardiac index sometimes around 2, to the very bare minimum, 2.2. Okay? So what's the difference between a mixed venous sample that is an SVO2 and an SCVO2? Sometimes we get this confused. SCVO2 is a centrally drawn sample. Okay? So you ever heard of somebody say we're going to do a dirty thick calculation on a mixed venous? Okay. What they want you to do is they want you to draw this mixed venous sample like we did out of a distal port of a central line. What's the purpose in that? Well, it gives you an idea as to how well the oxygen use or consumption is right before it gets back to the atrium. Okay. Well, that's not the farthest we can reach. A true SVO2 is sampled out of the PA port, which is the best sample we could get. Okay, but there's about, literature says anywhere from 7 to 8% of loss of oxygen from the time you would get an SCVO2 back all the way into the heart, around and up and across to where you would draw it out of the PA distal port. So, I mean, a good rule of thumb is let's say you go to check a mixed venous on your patient who only has a central line. You check this and you say, well, my patient looks like they're not doing so well, so I'm curious about what my index is. We're going to do a dirty fix. So you draw out that mixed venous from the central line, and you look at your reference number, and it's 65. Okay, so that's within normal range normally for what we would accept. But you got to take into consideration, you've got to take off about that 7 or 8%, because that's not really a true reflection of what your SVO2 would be. Okay, so if you get that back, you could think, well, they're actually a little bit lower than what we actually thought or that number would be. Okay, if you're doing a mixed venous sampling of the distal PA, a true SVO2, then you're going to be able to go off this normal value. Okay, so that's the difference between the two, and sometimes that gets a little bit confused, but hopefully we'll clear that up. So one other thing to talk about is the PA catheter removal. Now, PA catheter removal, there's a couple things to remember about this. One, like I was saying, there's an obturator cap. So if you're going to be taking it out, one of the questions you might have for the physician is, are we going to keep the introducer? Because these are great central lines for volume resuscitation because it's a very large catheter. And make sure that you have an obturator kit if you're going to keep that catheter in place. So whenever you go to pull this out, there's a couple little tricky things about this, and it would be a good idea to practice this. Let me step over here. Now what I want to show you is you can see how well this is all like right up, and it's hard to see, how do I get this loose? The center piece, and do we have that other one that was floating around? That may be a good example. Let's look at that. Thank you. The center piece right here, there's a little barb right here, okay? And it's in line with the sidearm. If you remember that, you'll always know where it is, okay? That's an important thing for you to know where it is when you're talking about discontinuing these, because you need to unlock the catheter from the hub. Okay, so you can see you're in line here. So it has 3 positions. Right in the middle is unlocked. Okay, all the way to the right, all the way to the left is locked. Okay, so what you want to do is find and line up the space on this little cap right here, the sheath, into the middle position, which will be in line with this sidearm. Okay, sometimes it's a little bit hard to get that initially loose, so you have to kind of move it a little bit and wiggle it around. The main thing is you don't want to be doing that on somebody's neck if it's sutured in and you're going to keep it, okay? Because that's really kind of painful. Don't do it to me. Anyway, you can see the importance of that and knowing, see this has a middle position and then a lock on either side. So if you always remember that that little barb that it hooks on is in line with the sidearm, with these type catheters, that's what's going to be consistently the same, okay? So if you are going to keep this, we go about DCing this. We don't want to pull it like a weed eater cord. We want to pull it nice and slow. Make sure you're pulling the catheter out at a steady pace. What are some of the risks when you're pulling it out? Before you pull it out, you always want to verify that your balloon's down, right? So, because you don't want to be pulling a beach ball on the end of that thing through the rest of the vessels, okay? Because that wouldn't be good. What about your Chandler wire? You want to make sure that that's been DC'd before you go and reposition. You go pull that catheter out. If you happen to have a Chandler wire, always, 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 it has to be pulled before you discontinue the PA catheter, okay? When you go to pull this out, steady, and you'll steadily pull it out. Whenever you're going through the different chambers, you're going to see the waveforms that we saw when we were inserting it in reverse, right? So we're going to go from your PA to your RV, and then from your RV. While you're in the RV, it's actually probably pretty normal to say that you're going to get some ectopy because it's going to bump around in there. One of the other risks whenever you're discontinuing a catheter, just like it would be for insertion, would be if there happens to be wrapped around a chordae supporting valve. You may want to, if you're pulling it out, you don't want to pull it really hard and fast because you don't want to pull and pop those chordae, because that could be now your patient has regurg when they didn't before. So, but you're going to pull it back nice and steady and slow. That should hopefully pull that out if it happens to be wrapped around one of those. The other thing that you have as a concern, and when you're looking at your x-ray, this is another good reason why you want to look at your x-ray, is your PA catheter may actually be twisted or in a knot. And you say, how could it be in a knot? Well, it's actually possible that it can be looped over itself in the ventricle and in a knot. So whenever you go to pull this out, you want to make sure that you're looking at that x-ray, make sure you have a straight, steady line from where you're coming in all the way around to the tip, so that you don't end up with trying to pull something out and it won't come out. Don't force it if it gives resistance. You want to know it nice and steady and slow, but if you do get resistance, you don't want to pull hard, okay? Other than that, the pulling of the catheter, really the main thing is if you're going to keep the line, you always want to make sure that it's acceptable and ready for reinsertion should you need to put another PA catheter in. Making sure it's nice and clean. Sometimes they get a little bit dirty. You can clean that off with ChloraPrep or swab, and then put your obturator cap on. Okay? So, other than that, for discontinuing it, can't think of anything else with that, so that's it.